Well, good afternoon, everyone. Very happy to be here and look forward to meeting many of you before the end of the day. So my name is Lee Cooper, and I'll explain a bit more about why I'm here over the course of the next few minutes. I'm somebody who likes open dialogue, so I look forward to a lot of questions after I'm through with these kind of opening remarks. And I'm particularly excited for questions with this group because it's a crowd that's right in the light. Very familiar with healthcare issues. People here have a uniquely intimate relationship with disease. And the one thing we all have in common, of course, is a dedication to alleviating the burdens of disease for patients, and by extension, their families and caretakers and communities. And so I guess just to get a pulse of the room, though, easy participation. You just have to raise your hand. You can raise your hand multiple times. Who here works in oncology or hematology? Oh, wow. That's even more than I expected. Neurology and CNS. And I guess I put musculoskeletal disease as well in there, maybe. Okay. Ophthalmology and dermatology. Cardiovascular. Rare genetic disease. Infectious disease. So I'm not surprised, and probably a lot of you aren't either, there's only 2 hands up for infectious disease. And I think that's worth noting, though, at a forum for advocacy. While the FDA approves almost 30 new drugs a year on average now, as far as I know, the only diseases that have been not just cured, but actually eradicated, thanks to modern medicine, fall in the infectious disease bucket. And look at the case of polio. Forgot my opening slide. Polio was a scourge in this country for 100 years. In 1952 alone, there were more than 21,000 cases of polio-induced paralysis and more than 3,000 deaths, the majority of which were children. And Americans in 1952, although maybe not everybody here in 2017, would have all been familiar with this monstrous device known as the iron lung. The iron lung was actually cutting-edge technology at the time. It might not look like it, but the iron lung enabled polio patients to breathe. They'd been so depleted in their nervous systems from the polio virus that they couldn't breathe on their own. But just 3 years later, in 1955, polio started to go away. And a couple years after that, it was almost gone. Communities, parents, the entire country didn't have to worry about this disease anymore. It wasn't just treatable, it wasn't just curable. It was actually out of people's minds. Cancer didn't go away. Cardiovascular disease didn't go away. Multiple sclerosis didn't go away. Tay-Sachs, cystic fibrosis, they didn't go away. Polio did. It was eradicated, eliminated, thanks to the introduction, as many here know, of the polio vaccine. And the polio vaccine was brought to patients thanks to the work of a few passionate scientists and the work of a nonprofit called the March of Dimes. In the case of polio, there was actually no new treatment, no new therapy. The FDA didn't approve anything to treat existing patients. What it was an innovation that could stop the disease before it even started. You could eliminate a disease by prevention. And with it, the social, medical, economic, and emotional costs that came from new cases of polio evaporated. And since then, they've been evaporated. They don't exist in the United States. I started thinking about polio earlier this year because of a personal experience. As Bob mentioned, I work in life sciences. My career has been dedicated to bringing innovative health technologies to patients. I'm trained as a lawyer and as a management consultant. I've held different roles across healthcare organizations, and I'm currently working to build a biotech company in Kendall Square called Moderna Therapeutics. My roles there have spanned corporate development and business development, investor relations and financing, helping to enable our scientists to bring, hopefully, breakthrough treatments to all sorts of diseases. But less than a year ago, on a Sunday night, I went to bed, hoping to get some rest for the work week ahead, and I didn't wake up in the morning. In my sleep, I'd experienced a sudden cardiac arrest. My heart had stopped. 9 out of 10 people die from a sudden cardiac arrest, so I was truly lucky to survive. I survived and I recovered, which is even more miraculous in my mind, thanks to outstanding emergency care from my wife, and then from an outstanding team at Tufts Medical Center down the street. And the reason I had a cardiac arrest is because I have a rare genetic disease, also card-carrying member. My disease is called long QT syndrome, and until that night it had been undiagnosed. And long QT is a disease that leads to stillbirths. It's the leading cause of sudden infant death, and it leads to teenagers collapsing on high school athletic fields, never to wake up again. Their hearts just stop, like mine did. But I was lucky. I recovered. And so I went from working on vaccines and rare disease therapeutics to also being a rare disease patient. And like many rare diseases, mine is one that comes from a single mutation in my genetic code. It's a monogenic disease. That is, of the 3.5 billion letters of my DNA, there's a single typo. It's like taking a full volume of the Oxford English Dictionary, stacking it 5 high, doing it again, then finding a single typo in a single letter buried in those pages. Upon becoming a rare disease patient, I felt intense anxiety, not about myself, but of passing on that mutation, that typo, to my children. To me, the way I started thinking about it, it felt like I'd be passing on polio, but it would have come from me, child's father. And worse, it's a pre-existing condition that I knew about. You can imagine, and many people here know the feeling, it's a devastating feeling to knowingly pass on a disease. And it's a feeling that only more people will have, as diseases that we all carry, that everybody carries, are defined by genetics. And when I say the word genetics, or gene, or genome, what comes to your mind? Is it the Human Genome Project and DNA sequencing? Is it Richard Dawkins' selfish gene, reproduction, sex, family? I imagine for most of us, when I say gene or genetic or genomic, what comes to mind is some aspect of a biological inheritance. It's an inheritance that gains increasing clarity every day, right here, thanks to the genomic revolution that's happening, particularly in Boston and in Cambridge. It's an inheritance that comes from our grandparents and get passed down to our parents, and then to us and our siblings. And most importantly, it's an inheritance that will continue on to our children into the future. And yet, most medical practitioners and patients are overwhelmingly using genetic information to look backwards. A woman may use her genetic information to uncover the cause of a tumor, to discover her ancestry, or to diagnose a disabled child. This is powerful stuff, and it's very important stuff. But it is fundamentally backward-looking. Ancestry and diagnosis describe how we got to today. And today, I believe we are all due for a frame shift in the way we think about genetic information, the way we use genetic information as advocates, to look forward and not just backward. Make sure I'm in the right place. And so, the way that polio, a generation ago, was able to eradicate a disease that killed thousands of innocent children every single year, today with the power of genomics, we can do the same thing for genetic disease. We can ensure that our children are never born with Tay-Sachs, or CF, or hemophilia, or in my case, long QT syndrome. We can stop diseases before they can start. And this isn't science fiction. This isn't crazy. Thousands of people are already doing this. There's already technology to do this. There's a technology called pre-implantation genetic diagnosis, or PGD. And PGD was invented to help prospective parents who know they carry disease-causing mutations to have children that are disease-free, to have healthy babies. The way PGD does this, again, for thousands of patients already, but it should be hundreds of thousands. The way it does this is by letting those parents look through those copies of the Oxford English Dictionary, their DNA, and find the disease-causing mutations. They can do that in every one of their embryos and select the embryos that are disease-free. No editing, no modifying, just setting aside those typos and keeping the volumes that are intact. And so if so many people are doing this, and if the technology is already there, why aren't we hearing more about it? Why aren't more people doing it? Why isn't it part of the normal course of treatment today for genetic disease? And I've come across two prevailing reasons why this is the case. The first is awareness, something people here know much about. It's awareness of the power of genetic information, and particularly carrier screening, to identify deadly genetic diseases, even in seemingly healthy people like me. And beyond awareness, it's a misperception about the actionability of genetic information today. As the genomics revolution matures, and as the word genomics itself becomes something of a buzzword, we need to do a better job of communicating the ways that some genetic information can actually prevent disease. And so the idea of awareness and action, they really sunk in with me over the last many months, almost a year now since I was diagnosed. And awareness and action are the reasons that I recently founded the Institute for Genetic Disease Prevention, a not-for-profit think tank dedicated to education and awareness and ethical access to these technologies. The way I see it, there's a gap in our ecosystem. That is, the ecosystem being public health and patient advocacy. And not with respect to any given disease. People are very good at that. People are good at helping patients to feel more comfortable in their skin, to make society aware of these conditions, to raise money to develop new treatments. But there is a gap in an understanding about carrier screening at large, and the power of genetics, and the actionability of genetics for all these diseases. And so my intention is to work with collaborators across all different specialties in this field, whether it's patient advocacy groups or biopharma, molecular diagnostic companies, payers, bioethicists, genetic counselors, medical geneticists, you name it. There are lots of people involved in this field. My goal is to be a gap filler and a connector and work with those people and help advance the cause of carrier screening. Because with carrier screening, we can reduce disease. The magic, and it really feels like magic, of eliminating a disease like polio, that magic happened because scientists and public health leaders were able to convince the public of the power of not treatment, but prevention. And prevention is always the cheaper option than treatment. And so as soon as we begin using genetic information as a forward-looking tool, we can stop diseases before they start. That when future generations of public health leaders, advocates, healthcare professionals are sitting in rooms like this, thinking about the opportunities, thinking about the drawbacks of the state of their field, they'll look back on us, and at this time, the genomics revolution, and they'll look to us as a case study of not only how to alleviate or to cure disease, but actually reduce the burden or eliminate the burden of disease for all future generations. So that's my opening remarks, and now I'd love to hear your questions and have a conversation about it. Thank you. Great. And I guess I'll stand here, up here alone. But, are there any questions to kick it off? I'm sure there are some. Yeah, right here up front. It's a great question. And I don't want to speak on behalf of that industry because I work in drug development, not in molecular diagnostics. It's an area I'm. Oh yeah, so the question was, how do I feel about 23andMe and other direct-to-consumer testing as an avenue for this sort of, I guess, giving people the knowledge of the diseases they carry? And so I think when you say 23andMe, it actually brings to mind not just carrier screening, but of course, ancestry testing and other bells and whistles they throw on. And of course, the DTC nature of it actually sometimes, I think, dominates the conversation over even the information they're giving people, right? Because that becomes a bit of a question with the FDA and other agencies. And I would say, I think anything that increases actionable genetic knowledge is important. But I'll also say that, and I alluded to it in my opening comments, I think one of the flaws I've seen, both from an industry perspective and now as a patient, is how much noise there is out there in the world of genetics. And so I don't want to be a naysayer because there's a lot of exciting, interesting companies popping up, more of them actually on the West Coast, I would say, than in Boston, related to genetic analysis and direct-to-consumer testing. But they do also create a lot of noise. And that's, I think, part of the problem. And that's why I'm emphasizing the actionability of these things. the way it can actually influence what we do in family planning and how we think about our families and ourselves and our health. Because while it's fun to get a scarf with your DNA printed on it, right? Or tell you which wine you like more or less. I never understood. I don't know why you wouldn't want to taste the wine yourself, but those things are valuable. What matters is not whether it's coming from 23andMe or coming from someone in a lab at a world-class institution like Beth Israel or the Brigham, but it's what's the actionable information? How do consumers differentiate what's actionable and what's just fun? And how do we ensure that the medical community is communicating that? And that's where the awareness comes in. As a patient, I can say, first, I'd done 23. I was an early adopter. Like many people in this room, perhaps, you work in this industry. I do think that stuff is kind of fun. I want to be part of the science. I'm happy if they use my genetic information to find new cures. I'm cool with that. I don't need to get a penny from it. But the problem, of course, is I then kind of felt like I was free from the risks of genetic disease, right? And that was about 7 years ago, probably. Again, I was an early adopter. And so for 7 years, I was like, great. And I come from a Jewish background. And of course, there are certain genetic diseases that are overweighted in Ashkenazi Jewish populations. So I was like, great, I'm clear of those diseases. Whenever I choose to become a father, I'm not going to be passing on anything. But of course, that wasn't the case. And even me, a relatively educated consumer who works in this field and understands some of the science underlying it, it just didn't cross my mind that there's thousands of more diseases that I didn't get tested for in that one CLIA-certified 23andMe direct-to-consumer test. And so again, going back to your original question, I think it's important to get the information out there to consumers, but the information piece is what's most essential. It's what are you getting? And this is where the role of genetic counselors is enormous. And there's a shortage of them in this country, and I think it's a really important and emerging issue. How do you communicate with the patients? And how do you tell them what is there, what isn't there? And what's important, not just within one company's test, but from company to company that's out there doing this stuff. Yeah, there. Yeah. Thank you. And I take it you're a genetic counselor. Yeah. So I'm glad I made that comment. But I really do feel that way. And I piggyback on it. There's two additional things I'd say about genetic counselors. One is that there is generally a shortage, and we need more of them. We're living in a genomics era. More and more diseases are defined not by any sort of clinical manifestation, but by a genetic marker or a genetic mutation. And so that's essential. The big thing that interests me, and that's why I've gotten into this more of an advocacy role now, and day by day it's increasing, and why I'm excited to be here and listen to people before and learn more from people here, is it's like many things in medicine, it's when and how do you get to that genetic counselor, right? And I know the story, I know it from the therapeutic side, many people here who come from industry know it as well. You hear stories about patients who took years to get diagnosed for a rare genetic disease. And it's because they bounced around to different doctors, the wrong doctors, people didn't understand. And I think the world of genetic counseling is actually, there's a similar problem, which is how do we streamline the process to get people in front of the genetic counselor in the first place? And how do we get that process to happen, what I would call further upstream? Not when you already think you have a disease, and not when you're already pregnant. If you're being referred by an obstetrician to a genetic counselor, you're already pregnant. And so there's already a baby growing, possibly, or an embryo growing at least, that does or does not carry a potential lethal or highly morbid disease of interest. And so we need to move upstream. Why aren't all people of childbearing age getting carrier screening? And people may disagree with that, but I believe that should be the case. I think every single person of childbearing age, not mandatory, but I think it should be more a normal course of primary care interview for any 18-year-old, man or woman, or probably younger than that. And so that's, again, it's about getting people to the genetic counselors that are capable of helping those people make informed decisions.
So as a mother of 2 boys with Duchenne muscular dystrophy, who is not a carrier of the disease, I wanted to bring up a very important point where it's our first generation of Duchenne muscular dystrophy. I also have 2 healthy kids. My genetic counselor years and years ago told me that I did not have a chance of having more children with Duchenne because both boys were spontaneous. We, of course, know more now, but luckily they are healthy. I have a healthy son and daughter. But what would you say about the many diseases where it is, carried in the woman's eggs, and they would pass a genetic carrier screening? So what are we going to do about that? By the way, Duchenne muscular dystrophy, most of the people I know don't have a family history and are not blood carriers of the disease.
Thank you. I think everyone heard. The question was, more or less asking about diseases that either don't manifest in the family pedigree ahead of what appears to be the first generation having the debilitating disease, or de novo mutations, right? And of course, different diseases are different in that way, right? For example, was it NF, neurofibromatosis? That's one where the 50% of the cases are de novo mutations, right? So 50% of those children, their parents are absent any variant that suggests that they're going to have a kid with this potentially devastating disease. And I guess there's 2 pieces to that. One is, I think because you can't stop all cases doesn't mean you shouldn't try to stop half of them, right? I think that's the first point I would make. But the other is just to clarify. So broadly, what I'm advocating for is carrier screening. But it's for a reason. It's to inform family planning decisions. And the question is, what are those decisions that you can then make? What is actionable about what I'm talking about? And so there's a few things. So for example, if there's a mutation only in the gametes, you would catch that if you did pre-implantation genetic diagnosis. Of course, if you don't know that you have it, there's probably no reason in this time to do pre-implantation genetic diagnosis. In the future, maybe when single-cell sequencing becomes easy in a sense, that could become a normal part of pregnancy. That's science fiction. I think that's more in the future. But it's a great question, and I don't. It's difficult, and even my disease. So long QT syndrome, for those who don't know, there's a lot of diseases out there. Of course, there are autosomal dominant diseases, and for some reason they get, I think, shorter shrift than some of the recessive ones. And part of the reason is there's more variable penetrance, right? So you may have the disease, but the clinical phenotype you have could vary a lot. So by definition, my mom and my grandma are carriers. They gave it to me, but it means they also have the disease. It's a dominant disease. But they didn't know that because they never had a cardiac arrest that killed them or almost killed them at a young age. But my great-grandfather did, right? And again, before the age of medical genetics, people thought he had a heart attack at age 40. But he obviously didn't have a heart attack. He was a healthy guy. He clearly had my disease, and he died at age 40 after childbearing age. Passed that on. 2 generations went by. No one had anything. And then I almost died at age 30, right? And so you're not going to solve all these cases, but I think through carrier screening and improving the knowledge, and again, improving that funnel to genetic counselors and to the technologies that are out there, you can at least reduce the burden dramatically. And I think that should always be the goal, is to reduce any suffering that we can. Right here.
So I guess one question I had would be, what would you classify a genetic or actionable genetic information to choose embryos and whatnot? Like, would you be concerned that that would lead to maybe the eradication of people being born with Down syndrome or any of those types of genetic abnormalities?
So the question is, how do you define a genetic disease for which you might look into what an embryo is carrying? And I think, so I'm not sure exactly where I'm not sure I fully understand the question. I mean, there's definitely a range of diseases that one could look after. I think my organization and I myself focused on lethal and highly morbid monogenic diseases, right? And so those are generally things that lead to high mortality rates in childhood. And that's not the only factor, but there's thought papers out all the time from the governing bodies for medical geneticists, genetic counselors talking about these things. How do you weight these things? And the diseases that appear, for example, on prenatal screening, a lot of those are the exact diseases that are the lethal and highly morbid diseases that we could be preventing if you just tested the parents before, not the baby the day it's born. And so those are the sorts of diseases that I'm trying to focus on. I think they're highly preventable and they're highly lethal, or at least highly morbid, significantly reducing the quality of life not only of an individual but of an entire family. So great question. So not going into the technical details too much, but there's two different names for different tests that can occur on embryo. One is called pre-implantation genetic screening, and one's pre-implantation genetic diagnosis, PGS and PGD. PGD is when you have a monogenic disease that you know of, a lab can create a probe, looking for that exact mutation. And then basically you make two piles of embryos. One's the ones that have the mutation, one's the ones that don't. PGS is looking for chromosomal abnormalities. And so you can do that, and most people tend to do that when they also happen to be looking, if you're already looking at the DNA material of an embryo, you also tend to look for chromosomal abnormalities. And so they're not necessarily coupled, but they often are. But they're different, in today's technology, they're different processes. Yeah, right there.
I think that you have a wonderful way of thinking, shifting from treatment to prevention. And I'm wondering, because this kind of prevention is going to be expensive, are you going to engage the payers when you get there?
Great question. So the question is one of cost, right? As is pretty well documented, vaccines have gone down in price exponentially since they first arrived, and even then they were pretty cheap, right? People, you can vaccinate entire communities for a few dollars. Genetic testing is also going down exponentially in price, so it's becoming much more widely affordable. And I think the broader answer to your question is, I think the health economics, and I have to prove this, and this is one of the early projects that we're working on, is the health economic analysis of this. And I think it's a no-brainer. $50,000 for IVF combined with PGD is literally a tenth of 1 year of treatment for some of the drugs that people in this room advocate for. And so I think you've a no-brainer right there. And again, with the expensive part being the post hoc analysis and the rapidly decreasing prices of the early part, which is the carrier screening, I think the health economics are going to work themselves out very nicely within a couple of years. So I think there's a lot of great conversations to be had, not only with payers, but also self-insured employers who want to just offer their employees this option. I think you'd end up saving a ton of money. If you eliminate one case of a disease that requires enzyme replacement therapy for several years of life, let alone the additional hospital costs and expenditures and other medical care and the teams that have to go into analyzing every problem that a child has and monitoring the mother during pregnancy sometimes, I think $50,000 for the whole kit and caboodle, and that's going to go down in price, is actually a bargain. So it's something, the actual numbers have to work out that way, but I'm pretty convinced that they would. Yeah.
Hi. Well, you're talking about really leading edge science and emerging science. And oftentimes, both in this, let's say, field, as well as other types of technology, when they emerge, we find that the culture in our society aren't quite ready for them. And so I'm sorry about this very large question, but any thoughts and ideas you have specifically in this area about how do we start to tackle those things? You know, in our area, we often say, oh, we need to educate people, we need to educate. And I think that's absolutely true. Sometimes it can come off as quite condescending. There are some really bigger, deeper, value-based things going on in society, not just recently, but you know, over time, how culture changes. And so I'm just wondering, what are your thoughts about that for this particular area, about how we might start to evolve so that culture can catch up a bit more with the science and the opportunities?
Yeah, I appreciate that question, and that's sometimes that's the elephant in the room. I'm surprised it took that many questions to get to that. I think one of the reasons I even got interested in this is I do have a little bit of a background in bioethics, and I think the bioethical piece is fascinating. And to me, again, I think nothing is black and white, but I think it's actually a lot less gray than some people initially think when they hear about this. And that's my intuition, and I'm continuing to speak to experts in the field and write on this myself and with others. And I think, like many people, as they hear this idea more and it starts to sink in, I think they'll agree. And let me just talk about a couple. There's a lot of pieces to this, but only talk about a couple, and then if other people have follow-up questions, we can talk about it. But this is a really important topic. First of all, it's actually not that new. PGD is pretty new, the latter part that I'm speaking of, that I spoke of a bit. But even then, it's been a couple decades, and now several thousand people a year use it, and the rates of error are extremely low, and technology is only improving, like many aspects of life sciences. So I think there's actually a misperception there where I think the technology is cutting edge, and you need a high-quality lab for sure. You don't want to send this to some random shop down the street, but the technology is there. In the 1970s, there was a huge campaign to eliminate Tay-Sachs in the Jewish community. And in about 40 years, the rate of Tay-Sachs births in this country has gone down more than 90%. And again, many people may know Tay-Sachs skews heavily towards Ashkenazi Jewish populations, as well as Irish populations and some others. And but some leaders in the Jewish community saw it as a big enough problem that they wanted to create local community-based public health efforts around Tay-Sachs. And many of you may know this. It's generally seen as a great success story, but a success story that's all about not forcing, but heavily persuading all people of marriage and childbearing age to get tested, to know what they were going into a relationship with in terms of their partner for a recessive disease, and to think about childbearing alternatives if there were two parents that were carriers. That could be not having a child. That could be monitoring closely with prenatal screening and amnio screening and terminating a pregnancy in the first trimester. It could mean PGD. It could mean getting a surrogate or a sperm donor. There's a lot of things it could mean, or it could mean having a child, taking the risk and having a child, but having the wherewithal to know that you may have to plan economically or practically your life a little bit different 9 months down the line, as opposed to the moment the baby is born, okay, what do we do right now? And I think the Tay-Sachs case is a fascinating one because one of the first things I often hear about this is this feels a little funny, and I don't know if people will take kindly to the idea of changing the way we think about our genes ahead of having a child. Admittedly, I've never read a single article or spoke to a single person that speaks negatively about that Tay-Sachs campaign. And again, maybe I'm speaking to the wrong people, and this is before I even got involved in this, right? You always hear about it as a success story. And I think part of that, and I think when you start to unpack why, I think that's where you get into the interesting stuff. You talk about human psychology. The Tay-Sachs example, that case study, happened in a pretty homogenous community. It happened amongst New York Jews, of which I am one. And within that community, again, because I think it's a homogenous community, and it was a grassroots campaign that happened from public health and religious leaders within the community, there was a lot of trust built early on. There was no skepticism about coercion or about the government trying to do something to your body or about some other nefarious entity out there trying to do something to you or trick you. And also the homogeneity matters, right? We read about this all the time in social science, whether it's social welfare benefits or voting habits. People in homogeneous communities act differently than people in heterogeneous communities. And that doesn't mean that there's no roadblock. That means there is a roadblock because we live in a heterogeneous world, in a diverse world. But what it does suggest to me is that when people cry foul on the morals or the ethics underlying some of these things, they're actually missing the point. I think it's more about cognitive biases and social taboos rather than actual underlying ethical concerns. And so that's the way I've been trying to think about it. And I think as advocates, that's the way you always have to think about things, right? You have to divorce what's really an ethical concern versus what's maybe socially awkward to talk about. And then try to dig deeper. And never push people from behind going somewhere they don't want to go. You have to lead from the front and encourage people with ideas that you think are watertight, or if not watertight, or at least compelling. And I think that's the way to approach this. That's a high-level answer to your question. Any other questions? None. All right. So everyone's going to be advocating for PGD now. No questions. Okay. Perfect. One room at a time. So will insurance cover it? So that goes back to the earlier question. I think for many reasons, we're lucky to live in Massachusetts. Massachusetts has very liberal policies when it comes to both IVF and IVF for the purpose not of infertility, but for if you have knowledge. And so a lot of health plans in Massachusetts actually do cover this pretty well if you go into it, you know, if you're an advocate for yourself, like many things in healthcare. But even states like California have horrendous coverage. And that's something that needs to be worked on. And that's in my line of sight as well, is working on this and making this known. Again, from the health economic perspective, I think there's a really strong case to be made. Whether you're talking about a local health plan, national plans, you know, federal plans like Medicaid or Medicare, or self-insured employers who manage their own health plans. I think there's a really strong case to be made, and I think that needs to be made. And that's part of why I want to be another voice in the room, because I'm not advocating for any given disease. I think there's a lot of great people already doing that, and nor am I advocating for a given technology. I just think that the genomics era needs some frame shifts in thinking, and I think we could start thinking about prevention. And I think it's both economically and morally the right thing to do to reduce the burden of disease. Yeah.
The genetic counselors in the room may have a better answer to my question. So as I'm listening to you and I'm hearing about health economics and health insurance, I'm wondering, when a family chooses to use PGD or PGS, how much of the genetic information is then given to the insurance company? Nowadays, insurance companies, for the most part, get all of the information. And my concern, say, let's pretend I'm a potential mom. What information do I have to give the insurance company to get the information I need just for the disease at hand? Does that make sense?
That's a great question. And so, again, maybe there are genetic counselors who know the technical answer better in terms of navigating different health plans. But the high-level answer that I think you're alluding to, and it's a lot of people's concern with a lot of these issues, is, of course, for a payer to pay for you to have a procedure that is dependent upon a genetic mutation, you're going to have to show them evidence of that genetic mutation. And there's worries about that discrimination and what could happen after, and what if that information leaks out. And Bob was whispering to me, the first thing that came to my mind, too, is the importance of GINA, right, which was federal protection for genetic rights, or for the genetic information non-discrimination act. And that was put in place several years ago, but this current Congress, of course, among many things they're doing in healthcare that don't always make sense, we're thinking about reversing that, or weakening the powers of GINA. And that is a concern, because any government could at some point reverse that. And so there needs to be some level of trust. But I think that speaks to another cause that everybody in this room probably can get behind, which is the importance of a GINA-like bill, whether it's on the federal level or the state level, maybe even local level, right, is protecting citizens who are using their genetic information to make informed decisions, to make decisions that are going to help the health of themselves and other individuals and their family and their community, so they're not discriminated against with unaffordable health care or employment, being blocked out of employment for whatever reason. And so it is a big concern, and it's kind of a big parallel issue for advocates to think about. Yeah.
I'll be honest with you. This conversation really advocates for the kids with Senator Kennedy
Yeah.
on that year. And the whole question, the reason we wanted that was I guess, and I'm grateful for what you do.
Right.
I think this is a really important public health discussion. It needs to happen. I just don't want to be a part of it.
Sure.
Doing it with really so no, it's important. But like what scares me about switching to the eradication of disease,
Yeah.
public health discussion,
Yeah.
come up with therapy. That's the mode that a lot of us are in.
Sure.
But
I think
so how do you deal with that?
it's
Like,
such
is
an
there a
important.
therapy or a treatment?
That's a great, it's a great point, and I think it goes without saying that I think they're not inconsistent efforts, of course, right? I think they're important parallel efforts. We need to keep treating. I work at a biotech company. I'm hoping to make breakthrough cures. We actually have a partnership with Vertex to hopefully make a more effective CF treatment that could treat all genotypes and not just the ones that are currently treated by their molecules. And so I think those are really valuable. But the amazing thing about the therapies that are happening today is that they're enabling more people who carry these genetic diseases to have kids. For the first time ever, there's a pretty big bolus of people who have cystic fibrosis who are having kids. That wouldn't have happened 50 years ago. So if anything, this is actually more important. You have more people entering prospective parenthood who are carriers of disease, and that could continue. And to me, the effect of genomics should be the opposite. I'm actually always shocked that the rates of diseases like hemophilia haven't gone down with, the way that we can, people know their family's pedigree now out many roots along the family tree because of the treatments, right? And that's what, when you launch a disease at a biopharma company, part of your job is to raise awareness and to improve screening and improve genetic testing so people understand their whole family tree and who's impacted, who's not. And if anything, it's better enabling the ability for us to reduce the burden for future generations. And I sincerely hope that we keep working on drugs for your son. And I have a implanted defibrillator that I wear without choice every day. And I'm going to have to get that replaced every few years. And I surely hope that, 7 years from now when I have to go back into surgery and get another defibrillator put in, that the battery life is 10 years longer than this one was, right? Or that it's, half the size, that when I go running, I don't feel it hit my arm. And that's, I'm comparatively lucky to many of the genetic diseases, like the one that you're very familiar with, in that my daily quality of life, I think, isn't impacted as much. But I wear a daily reminder of the disease I have that my heart can stop. And so I want that research to continue, and I think it can and will continue, and I think there's a drive for it. But I also don't want to have a kid that has to have the next generation defibrillator. I want him to have no defibrillator, right? And so it is a struggle, though. There's a tension. But looking at I think, again, we can look at the infectious disease world where eradicating smallpox and polio didn't stop people from making more antibiotics, right? Or antivirals in that case, more accurate. And so I think these different patient-focused efforts can exist in tandem and can actually feed one another, right? Because the learnings from one can help the other. And again, I'm advocating strongly for this, but I attended my own advocacy group's meeting, a couple weeks ago, and I didn't even talk about this because that place that wasn't the subject there, and what people needed there was a community to be a part of, and they needed to understand the latest treatments, and they needed people who understood their story and they could share their own, and needed practical guidance on their day-to-day life. So I saw quickly this wasn't the topic to bring up, and I was happy to just be a part of that community for that weekend in that way. But then I came home and I started writing my next article about this, right? And I think they can exist in concert. So, but it's a great point. I think, I'm really glad you brought that up. I think of all the ethical arguments around any sort of approach or technology related to whether gamete screening, embryo screening, or just other forms of prospective prevention of disease, not just genetic disease, infectious disease as well. I think the most compelling ethical reason against it, to me, is this: is inequality, right? And you worry about inequalities that could arise. And again, you come back to the discrimination question. But just because it's a concern, I do think it's surmountable. And I think it's very important to keep it in mind. I think it's a very real concern, and I wouldn't belittle it at all. Again, I think by analogy a lot, but I do look back to vaccines, right? This is like the year they think they can cure polio for the rest of the world, right? The U.S. was basically, polio was eradicated in the U.S. by the 1950s. The international campaign began around 1980. The Gates Foundation accelerated it about 10 years ago, and now polio is almost gone. I don't think there were any, so for 40 years, there were inequalities around the world in terms of a lethal disease completely paralyzing and mutilating some children. And in the US, we didn't have to think about it. And that is a reason maybe why more polio research didn't happen. But at the end of the day, I think with the US as an example, it then spread around the world, and polio might be gone not only from the United States, but from planet Earth within a year or two from now, which is remarkable. And so I think, there were probably inequality questions all along the way with that, but that's the role of foundations, and that's the role of government, and that's the role of advocates, is to make sure that those inequalities don't persist, right? And I think you're never going to stop inequalities in almost any new, whether it's a consumer product or a healthcare intervention. You're not going to stop inequality. But I think the role of the advocate then is to make sure that those inequalities, A, don't lead to the denigration of anyone's inherent dignity that does still have the disease, and then B, that those inequalities don't persist. And so I think there's a strong human element to all this, and that's what we have to use to counteract all the, I think, wonderful positive outcomes that can happen when we think about prevention, be it in genetic diseases or elsewhere. That's how I feel about it. Great point. Yeah.
Hi there. So I am a former genetic counselor, and now I'm in drug development. And I've sort of appreciated listening to the different perspectives. And I've been out of genetic counseling for a number of years, but I think one thing that has always resonated with me as a genetic counselor was the fact that we were there really to provide information, but we weren't in any way coercing, forcing, persuading people to do certain things. By providing that information, we gave those people a choice, an informed decision, right, to make. And carrier screening has been around since I was as a genetic counselor, so for a number of years. And definitely, as you mentioned, in the Ashkenazi Jewish population, there's quite a number of different diseases you can screen for. But in that carrier screening, there was always information provided about how limited it was. I mean, to the fact with CF, there are so many different mutations, you can't screen for all of it. So you're always going to be limited to say, this is the answer, but the chances are there's still a % chance that you could still be passing something down. So whether it's inherited or not, or whether it's by sporadic, people still are left with their own individual choice. And I think you can speak to the public health issue perhaps, but I think we always have to come back to the individual and realize that people make decisions for very different reasons. And it became so evident to me. I think I walked into that world thinking I assumed I had an opinion, but it definitely changed what I thought, and recognizing how people can have completely different opinions to me, of course, and that's acceptable, and depending on where they are in their lives as well. So I think we can definitely provide the information as to what's available. Yeah, people would come into the office and say, I just want screening for everything. You can't screen for everything. And insurance is not going to pay for everything. You need family history. You need various risk factors. So there's always, I guess what concerns me is we can't sort of have, it does make me uncomfortable too, because I feel that we can't sort of expect, therefore everyone should agree that this is the way it's done. It is a little, makes me a little uncomfortable in that it sounds a little sci-fi in a sense, and that, you know, as long as we're all screened, you know, we'll start doing this matchmaking as a result. And yeah, certain societies, certain communities actually do that. But I think we have to respect an individual choice and realize that for some people, if you know that there's treatment, they might not choose, you know, something like pre-implantation diagnosis or screening. And then for others, what that means to go through is actually something they need to think through as well. So it's, I guess I appreciate this discussion, but it definitely, I think we just have to recognize there's a lot that we still don't know. There's only so much we can know, and I think no matter what, there's always a risk. You know, polio, yeah, that was not inherited. I mean, today we continue to discover viruses that we don't have cures for. So we're doing the best we can.
So I think it's a great sentiment, and you brought up a key word, which is coercion, and another word I think you said was agency, and those are two important themes to me. I don't think anything I've said is inconsistent with either of those. I think there's no place for coercion when it comes to almost any form of medical care, and except, I mean, there are some cases perhaps, but definitely not with anything related to genetics. And I think respecting individuals' agency is that's what makes good people, right? And so I think most people don't want to take away other people's agency. There's always some bad actors out there. And so, but I don't think they're inconsistent at all. But I will challenge you. I'm still not clear based on what you said what you're uncomfortable about. I think just because there's other viruses out there doesn't mean, just because Zika popped up doesn't mean we weren't working hard to make a vaccine for rotavirus or for cytomegalovirus. And just because polio was cured doesn't mean we stopped trying new things. Just because we know there's going to be another one doesn't mean we're trying to get Zika now. And so I think, again, I think it's important. I think sometimes this almost sounds more controversial than it really is in terms of when you think about the practicalities of it. Because I mean, a lot of people in this room advocate for gene therapy and gene editing. And I'm not even talking about gamete editing, even not germline editing. I think there's a lot of ethical issues with giving someone chemotherapy, where statistically you're not going to extend their life much and you're basically torturing them. Right? But we take these things for granted because we're comfortable with how we've used them in our society for decades. So that's the one thing I would challenge you on. And I totally agree with your sentiment about the other piece. But just because you're uncomfortable doesn't mean that you disagree or that you think it shouldn't be out there, again, as an option with completely informed consent for people to have in the toolbox when they're thinking about having a family. That's how I guess react to your very meaningful sentiment. Yeah. So you're running an advocacy. I would argue that it's better to be more explicit than not. Yeah. So can you explain what the milestones are, what you do, yeah. Hard to see from here to there. Sure. Actually, I have a backup slide. This is just as a background. I think I won't go into milestones, things like that. I think, and honestly, I'm still hashing those out. But with the people I'm working with, but I think it's a lot about what we've been talking about, right? Where I really deeply believe, and a lot of people that I've been engaging with who are members of all pieces of this ecosystem, a lot of people agree. You hear these ideas and they can be jarring because, again, we're just not used to thinking about prevention with genetics. We're not used to thinking about embryo screening in this way. But at the end of the day, I deeply believe that it's one of those things where if we educate people and give people the opportunity to use it as a tool and raise awareness and emphasize, again, the actionability of genetics. If you read a health economic study about genetic testing these days, it omits family planning. That's mind-blowing to me. What is more integral to your genetics than your family planning? And I dare you to go find one paper out there that talks about the impact of full genome sequencing or SNP sequencing, any type of genetic sequencing, that takes into account the decisions that parents can make about their family. I mean, genetics are, again, the biological inheritance that we share with our families. And to me, health is a fundamentally social phenomenon, right? You're not healthy for you. You're healthy for the things you can do with other people in your community. That's why you want to be healthy. That's what makes humans human, social creatures. And what's more social than literally the genetic information you share with your family? And so I think when we start thinking about it that way, and we do more writing and more speaking on that, and again, a big piece is thinking about the market access pieces of this and making sure that we reduce and minimize the potential inequalities that could arise from this, or just the unequal access, whether it's within a state, within the country, or around the world. I think those are a lot of things that I'm working on. So again, engaging with payers, engaging with major employers, and leaders in the field of bioethics and reproductive medicine. So it's a milieu of things right now, and we're going to sharpen that. And I think there's never been a public campaign about carrier screening that's been really broad and big. I think it's often been community-based. So I think that's something that I have my eye on. But yeah, that's an important question. Great.